Good day. I'm Dr. G.E. Golly, and I'm happy to be presenting a topic today on cleft lip and palate deformities, part one, and there'll also be a part two. But we'll start out with initially with part one. For those of you that don't know me, I'm Golly, and I am currently the director of oral and maxillofacial surgery, craniofacial and head and neck surgery at the Willis-Knighton Health System in Shreveport, Louisiana. That is the largest private healthcare system in North Louisiana. I have no disclosures. And as I mentioned, part one will be on cleft lip, both on the unilateral and the bilateral deformity. And then part two, ultimately on cleft palate, talking about hard and soft palate repair, as well as very important alveolar repairs. Just as an outline, cleft lip and palate repair, I'm going to talk a bit about in the introduction, a bit about the history and genetics of clefting, and a little bit about the classification schemes that are available, a little bit about timing, preoperative feeding, very important discussion on anatomy, because unless you really understand the anatomy of the cleft, it's really difficult to get an appropriate repair. And then ultimately we'll discuss surgical repair of cleft deformities, and hopefully your clefts won't be as wide or as large and as significant as this child on the right that has a Tessier cleft that we'll discuss later. Over the past quarter of a century, there's been a significant advancement in the ability to detect clefts prenatally. This is most significant in being able to detect clefts of the lip, and not as good for detection of clefts of the palate. But again, what you see here on your left is on high definition ultrasound, the same child that you see on your right, which is a complete bilateral cleft of the lip and end of the palate. And it's quite evident. And I believe you can see the area of the premaxilla here on the prenatal ultrasound, and then ultimately the premaxilla here. And we'll discuss more about bilateral defects in just a minute as well. But needless to say, there has been significant improvement in the ability to prenatally detect these clefts. Indeed, these clefts occur somewhere between 5 and 10 weeks in utero. Many times the mother is not even aware that she's pregnant at this stage. The embryology of cleft lip and palate occurs basically from the basic standpoint. It's failure of the median nasal prominence or median nasal processes to fuse with the lateral nasal process or lateral nasal prominence and the maxillary prominence or the maxillary process. It's the maxillary processes that then give sprouting out medially to create the definitive palate. You can see on this very crude diagram basically what develops from the maxillary prominence, a majority of the infraorbital region, as well as the maxilla. What is developing from the median nasal processes, the most of the mid portion of the upper part and the lower part of the nose, as well as the tip of the nose, the columella, and the philtrum, all develop from the median nasal processes. And then, of course, the lateral nasal process or prominence develops a majority of the lateral process of each of the noses, each side of the nose. And again, the area between the lateral nasal processes and the maxillary process is where the nasal lacrimal groove ultimately develops. When you look at clefts of the palate, again, I'm going to discuss in detail in part two about the palate, but just for an embryologic understanding, the palatine shelves are processes of the maxillary prominence or the maxillary process, and they fail to fuse at the midline. And this is what results in the development of a cleft palate. In theory, the tongue develops initially or originates initially in a very cephalic position, and descends caudally. Well, that failure of the tongue to descend can prevent the palatal shelves from coming together at the midline, resulting in a classic cleft of the palate. We see this sometimes in patients with Pierre-Robin, which we will discuss in just a few minutes, but it can occur obviously in other types of clefts as well. One of the theories is that there may be some intrauterine constriction embryologically that results in insufficient room, and the tongue does not descend caudally, and therefore the shelves don't come together. What about the incidence of orofacial clefting in general? When you see the abbreviation CL/P, this is cleft lip with or without cleft of the palate, because cleft lip itself is separate from clefts of the palate from an embryologic, obviously we just talked about that, from an epidemiologic, and from an etiologic standpoint. Clefts of the lip with or without clefts of the palate tend to demonstrate racial heterogeneity, meaning they occur in different races at a higher frequency or a lower frequency than in other races. Also, clefts of the lip tend to occur more commonly on the left side as opposed to the right side of the face. If you look at racial heterogeneity, and again, more races than you see here, but in the Native American population, almost 3 per 1,000 clefts is the incidence. In the Asian population, about 2 per 1,000, Caucasian 1 in 1,000, and in the African American and then just in the Black population in general throughout the world, it has a lower incidence of about 1 per 2,000 or 0.5 per 1,000 live births. Within each of these particular ethnic groups, there may be a higher incidence or a lower incidence. For example, in the Asian population, if you look just at the Indian subcontinent, this may be closer to 5 per 1,000 births. They have a very high incidence, though many of you have traveled and worked, done mission work, you know, there's very high incidence of clefting, clefts of the lip and palate in the Indian subcontinent. Cleft palate, on the other hand, does not demonstrate racial heterogeneity and tends to occur about 0.5 per 1,000 or 1 per 2,000 live births. This is an isolated cleft without any evidence of a cleft lip. Remember, with cleft lip, there is racial heterogeneity. Isolated clefts of the palate, there is not. What about sex ratio in orofacial clefting? Well, clefts that have lip and palate involvement and bilateral clefts tend to occur more often in males, and those isolated clefts of the palate tend to occur more often in females. If you look at the genetics of orofacial clefting, it can be best described as having variable expressivity and a multifactorial etiology. We don't really know what causes clefts. There are some ways to induce clefting in animal models, but in general, when it comes to humans, there's variable expressivity and a multifactorial etiology. There is a predicted recurrence that is based on affected relatives. This was first described by Ross and Johnston in 1972 in the Cleft Palate Journal. So basically, if you have a child that has a cleft lip and palate, and the chance of having another child with a cleft lip and palate is about 4%. If you have one parent that has a cleft, what's the chance of having a child with a cleft? It's about 3.2%. So both of these are both fairly low percentages. When you have one child with a cleft and a parent that has a cleft, the chance that the next child could have a cleft would be around 15 to 16%. So again, these are still fairly low numbers. They're not insignificant, but they are fairly low. And one way to look at this is and the way I counsel families is, okay, they have a child with a cleft. There's a 96% chance that the next child is not going to have a cleft. It's not 1 in 1,000, but it's certainly not more than 4% overall. What about the topic of syndromic clefting? As you guys know, there is a significant number of syndromes that have clefts associated with them. Overall, about 8% of the cleft population is syndromic in nature. It's one of three etiologies. Either it's a major mutant gene, as you see in Treacher-Collins or Stickler, or it may be a chromosomal abnormality like you see in some of the trisomies, or it could be a teratologic syndrome, like you see with dilantin, hypoxia, carbon monoxide, or alcohol-induced issues. So those are the three major sort of etiologies that you may see syndromic clefting in. Let's talk about some of the syndromes that may be associated with clefting. Classically, Pierre-Robin or Robin sequence or syndrome associated with a triad of micrognathia, small jaw, glossoptosis, where the tongue falls posteriorly and potentially obstructs the airway, and then the U-shaped cleft of the soft palate. Remember, that goes back to the failure of the tongue to descend caudally and obstructs the palatine shelves, which are extensions of the maxillary process, from fusing at the midline. Generally, there's up to 35, maybe even 40 associated syndromes that have Pierre-Robin as part of their association. The overall incidence is about 1 in 8,500 live births. Respiratory obstruction is sort of the hallmark of the Robin sequence, and the obstruction is of variable degree. That variable degree will help dictate what type of treatment, if any, is necessary. There may be some degree of failure to thrive. This kind of shows you here a child that's having some significant issues with the breathing, and in essence, this child has a lot of sternal retractions, which tends to be fairly pathognomonic with a severe obstruction associated with Pierre-Robin. This child may be a candidate for some type of procedure, whether it be a lip-tongue adhesion or whether it be a distraction of the mandible, hopefully not a tracheotomy. If you look at the Robin sequence, there's early mandibular hypoplasia. This occurs early, before 9 weeks in utero, as we mentioned embryologically. The tongue is posteriorly located, and this impairs posterior palatal shelf midline closure. This is out of Loray's Atlas, and what it shows is a demonstrable technique of lip-tongue adhesion, first described by Beverly Douglas in the management of Pierre-Robin. And this technique, you can't use every technique everywhere you happen to be in the world. There's in some parts of the world, distraction may be the way to go, and in some parts of the world, maybe the Douglas procedure. You may be somewhere where you don't have a distractor available. And this child here on the bottom is a child with Pierre-Robin that I did a very successful lip-tongue adhesion on, and they ended up doing quite well. When they were about 1.5 years of age, I released this lip-tongue adhesion, and